Hello, I'm Monica Manginsai, and I am doing the chicken leg and wing dissection lab. This will be the chicken leg dissection. We are studying a chapter on joints in my anatomy and physiology class, and the joint for the chicken leg that we will be looking at is the synovial joint. Synovial joints are those in which the articulating bones are separated by fluid-containing joint cavity. This arrangement permits substantial freedom of movement, and all synovial joints are freely movable diarthrosis. Nearly all joints of the limbs, indeed, most joints of the body fall into this class. General structure. Synovial joints have 6 distinguishing features: articular cartilage. Glassy, smooth hyaline cartilage covers the opposing bone surface as articular cartilage. These thin, 1 millimeter or less, but spongy cushions absorb compression placed on the joint and thereby keep the bone ends from being crushed. The joint articular cavity. A feature unique to synovial joints. The joint cavity is really just a potential space that contains a small amount of synovial fluid. Articular capsule. The joint cavity is enclosed by 2-layered articular capsule or joint capsule. The tough external fibrous layer is composed of dense, irregular connective tissue. It strengthens the joint so that the bones are not pulled apart. The inner layer of the joint capsule is a synovial membrane composed of loose connective tissue. Besides lining the fibrous layer internally, it covers all internal joint surfaces that are not hyaline cartilage. This synovial membrane's function is to make synovial fluid. Synovial fluid. A small amount of slippery synovial fluid occupies all free spaces within the joint capsule. This fluid is derived largely by filtration from blood flowing through the capillaries in the synovial membrane. Synovial fluid has a viscous, egg-white consistency due to hyaluronic acid secreted by the cells in the synovial membrane, but it thins and becomes less viscous during joint activity. Synovial fluid, which is also found within the articular cartilages, provides a slippery, weight-bearing film that reduces friction between the cartilages. Without this lubricant, rubbing would wear away joint surfaces, and excessive friction could overheat and destroy the joint tissues, essentially cooking them. The synovial fluid is forced from the cartilages when a joint is compressed. Then, as pressure on the joint is relieved, synovial fluid seeps back into the articular cartilages like water into a sponge, ready to be squeezed out again the next time the joint is loaded or put under pressure. This process, called weeping lubrication, lubricates the free surfaces of the cartilages and nourishes their cells. Remember, cartilage is avascular. Synovial fluid also contains phagocytic cells that rid the joint cavity of microbes and cellular debris. Reinforcing ligaments. Synovial joints are reinforced and strengthened by a number of band-like ligaments. Most often, these are capsular ligaments, which are thickened parts of the fibrous layer. In other cases, they remain distinct and are found outside the capsule as extracapsular ligaments, or deep to it as intracapsular ligaments. Since intracapsular ligaments are covered with synovial membrane, they do not actually lie within the joint cavity. People said to be double jointed amaze the rest of us by placing both heels behind their neck. However, they have the normal number of joints. It is just that their joint capsules and ligaments are more stretchy and loose than average. Nerves and blood vessels. Synovial joints are richly supplied with sensory nerve fibers that innervate the capsule. Some of these fibers detect pain, as anyone who has suffered a joint injury is aware, but most monitor joint position and stretch. Monitoring joint stretch is one of several ways the nervous system senses our posture and body movements. Synovial joints are also richly supplied with blood vessels, most of which supply the synovial membrane. Their extensive capillary beds produce the blood filtrate that is the basis of synovial fluid. Besides the basic components described above, certain synovial joints have other structural features. Some, such as the hip and knee joints, have cushioning fatty pads between the fibrous layer and the synovial membrane or bone. Others have discs or wedges of fibrocartilage separating the articular surfaces. Where present, these articular discs or menisci or crescents extend inward from the articular capsule and partially or completely divide the synovial cavity into two. Articular discs improve the fit between articulating bone ends, making the joint more stable and minimizing wear and tear on joint surfaces. Besides the knees, articular discs occur in the jaw and a few other joints. Bursa and tendon sheaths. Bursa and tendon sheaths are not strictly part of synovial joints, but they are often found closely associated with them. Essentially bags of lubricant, they act as ball bearings to reduce friction between adjacent structures during joint activity. Bursa or purse are flattened fibrous sacs lined with synovial membrane and containing a thin film of synovial fluid. They occur where ligaments, muscles, skin, tendons, or bones rub together. A tendon sheath is essentially an elongated bursa that wraps completely around a tendon, subjected to friction. Like a bun around a hot dog, they are common where several tendons are crowded together within narrow canals, in the wrist region, for example. The hip or coxal joint has the hip bone and femur as articulating bones. It is a synovial ball and socket joint, the structural type. The knee or tibiofemoral joint is the femur and tibia. It is a synovial modified hinge joint. It contains articular discs. The knee, the femoral patellar joint, is a synovial plane type joint. The superior tibiofibular joint is the tibia and fibula proximally articulated. The inferior tibiofibular joint is the tibia and fibula distally articulated. The superior tibiofibular joint is a synovial plane joint, and the inferior tibiofibular joint is a fibrous syndesmosis joint. Factors influencing the stability of synovial joints. Because joints are constantly stretched and compressed, they must be stabilized so that they do not dislocate or come out of alignment. The stability of a synovial joint depends chiefly on three factors: the shape of the articular surfaces, the number and positioning of ligaments, and muscle tone. Articular surfaces. The shapes of articular surfaces determine what movements are possible at a joint, but surprisingly, articular surfaces play only a minor role in joint stability. Many joints have shallow sockets or non-complementary articulating surfaces, or misfits, that actually hinder joint stability. But when articular surfaces are large and fit snugly together, or when the socket is deep, stability is vastly improved. The ball and deep socket of the hip joint provides the best example of a joint made extremely stable by the shape of its articular surfaces. Ligaments. The capsules and ligaments of synovial joints unite the bones and prevent excessive or undesirable motion. As a rule, the more ligaments a joint has, the stronger it is. However, when other stabilizing factors are inadequate, undue tension is placed on the ligaments and they stretch. Stretched ligaments stay stretched, like taffy, and a ligament can stretch only about 6% of its length before it snaps. Thus, when ligaments are the major means of bracing a joint, the joint is not very stable. Muscle tone. For most joints, the muscle tendons that cross the joint are the most important stabilizing factor. These tendons are kept taut at all times by the tone of their muscles. Muscle tone is defined as low levels of contractile activity in relaxed muscles that keep the muscles healthy and ready to react to stimulation. Muscle tone is extremely important in reinforcing the shoulder and knee joints and the arches of the foot. Movements allowed by synovial joints. Every skeleton muscle of the body is attached to bone or other connective tissue structures at no fewer than 2 points. The muscle's origin is attached to an immovable or less movable bone. Its other end, the insertion, is attached to a movable bone. Body movements occur when muscles contract across joints and their insertion moves toward their origin. The movements can be described in directional terms relative to lines or axes around which the body part moves and the planes of space along which the movement occurs. That is, along the transverse, frontal, or sagittal plane. Excuse me. Range of motion allowed by synovial joints vary from non-axial movement, slipping movements only, since there is no axis around which movement can occur, to uniaxial movement, movement in one plane, to biaxial movement, movement in 2 planes, to multi-axial movement, movement in all 3 planes of space and axes. Range of motion varies greatly in different people. In some, such as trained gymnasts or acrobats, range of motion or movements can be extraordinary. The range of motion at the major joints are given in the far right column, table 8.2 in this textbook. There are three general types of movements: gliding, angular movements, and rotation. The most common body movements allowed in synovial joints are described next and illustrated in figure 8.5 chart in this textbook. Next. Have the bones. Leg. Two parallel bones, the tibia and fibula, form the skeleton of the leg, the region of the lower limb between the knee and the ankle. These two bones are connected by interosseous membrane and articulate with each other both proximally and distally. Unlike the joints between the radius and ulna of the forearm, the tibiofibular joints of the leg allow essentially no movement. The bones of the leg thus form a less flexible but stronger and more stable limb than those of the forearm. The medial tibia articulates proximally with the femur to form the modified hinge joint of the knee, and distally with the talus bone of the foot at the ankle. The fibula, by contrast, does not contribute to the knee joint and merely helps stabilize the ankle joint. They are connected proximally to the femur, the single bone of the thigh. It is the largest, longest, strong bone in the body. Its durable structure reflects the fact that the stress on the femur during vigorous jumping can reach 280 kilograms per centimeter squared, or about 2 tons per square inch. The femur is clothed by bulky muscles that prevent us from palpating its course down the length of the thigh. Its length is roughly 1/4 of a person's height. And the bones of the leg are the tibia. The femur connects to the tibia, or the shin bone, and it receives the weight of the body from the femur and transmits it to the foot. It is second only to the femur in size and strength. At its broad proximal end are the concave medial and lateral condyles, which look like two huge checkers lying side by side. I believe that's the ankles. These are separated by an irregular projection, the intercondylar eminence. The tibial condyles articulate with the corresponding condyles of the femur. The inferior region of the lateral tibial condyle bears a facet that indicates the sites of the superior tibiofibular joint. Just inferior to the condyles, the tibia's anterior surface displays the rough tibial tuberosity to which the patellar ligament attaches. The tibial shaft is triangular in cross-section. Neither the tibia's sharp anterior border nor its medial surface is covered by muscles, so they can be felt just deep to the skin along their entire length. The anguish of a bumped shin is an experience familiar to nearly everyone. Distally, the tibia is flat, where it articulates with the talus bone of the foot. Medial to that joint surface is an inferior projection, the medial malleus, or little hammer, which forms the medial bulge of the ankle. The fibular notch on the lateral surface of the tibia participates in the inferior tibiofibular joint. The fibula, or pin, is a stick-like bone with slightly expanded ends. It articulates proximally and distally to the lateral aspects of the tibia. Its proximal end is its head. Its distal end is the lateral malleosus. The lateral malleosus forms the conspicuous lateral ankle bulge and articulates with the talus. The fibular shaft is heavily rigid and appears to have been twisted a quarter of a turn. The fibula does not bear weight, but several muscles originate from it. The knee joint. The knee joint is the largest and most complex joint in the body. Despite its single joint cavity, the knee consists of 3 joints in one, an intermediate one between the patella and the lower end of the femur, the femoropatellar joint. The lateral and medial joints, collectively known as the tibiofemoral joint, between the femoral condyles above the C-shaped menisci or semilunar cartilages of the tibia below. Besides deepening the shallow tibial articular surfaces, the menisci help to prevent side-to-side rocking of the femur on the tibia and absorb shock transmitted to the knee joint. However, the menisci are attached only at the outer margins and are frequently torn free. The tibiofemoral joints act primarily as a hinge permitting flexion and extension. However, structurally, it is a bicondylar joint. Some rotation is possible when the knee is partially flexed and when the knee is extended. But when the knee is fully extended, side-to-side movements and rotation are strongly resisted by ligaments and the menisci. The femoropatellar joint is a plane joint, and the patella glides across the distal end of the femur during knee flexion. The knee joint is unique in that its joint cavity is only partially enclosed by a capsule. The relatively thin articular capsule is present only on the sides and posterior aspects of the knee, where it covers the bulk of the femoral and tibial condyles. Anteriorly, where the capsule is absent, 3 broad ligaments run from the patella to the tibia below. These are patellar ligament flanked by the medial and lateral patellar retinacula, or retainers, which merge imperceptibly into the articular capsule on each side. The patellar ligament and retinacula are actually continuations of the tendon of the bulky quadriceps muscle of the anterior thigh. Physicians tap the patellar ligament to test the knee jerk reflex. The synovial cavity of the knee joint has a complicated shape with several extensions that lead into blind alleys. At least a dozen bursa are associated with this joint. For example, notice subcutaneous prepatellar bursa, which is often injured when the knee is bumped anteriorly. All three types of joint ligaments stabilize and strengthen the capsule of the knee joint. The ligaments of two of the types, capsular and extracapsular, all act to prevent hyperextension of the knee and are stretched taut when the knee is extended. These include the following: the extracapsular fibular and tibial collateral ligaments are also critical in preventing lateral or medial rotation when the knee is extended. The broad, flat tibial collateral ligament runs from the medial epicondyle of the femur to the medial condyle of the tibial shaft below and is fused to the medial meniscus. The oblique popliteal ligament is actually part of the tendon of the semimembranous muscle that fuses with the joint capsule and helps stabilize the posterior aspect of the knee joint. The arcuate popliteal ligament arcs superiorly from the head of the fibula over the popliteus muscle and reinforces the joint capsule posteriorly. The knee's intracapsular ligaments are called circuate ligaments because they cross each other, forming an X or cross in the notch between the femoral condyles. They act as restraining straps to help prevent anterior-posterior displacement of the articular surfaces and to secure the articulating bones when we stand. Although these ligaments are in the joint capsule, they are outside the synovial cavity, and synovial membrane nearly covers their surfaces. Note that the two cruciate ligaments, both run superiorly to the femur, are named for their tibial attachment sites. The anterior cruciate ligament attaches to the anterior intercondyle areas of the tibia. From there, it passes posteriorly, laterally, and upward to attach to the femur on the medial side of its lateral condyle. This ligament prevents forward sliding of the tibia on the femur and checks hyperextension of the knee. It is somewhat lax when the knee is flexed and taut when the knee is extended. The stronger posterior cruciate ligament is attached to the posterior intercondyle area of the tibia and passes anteriorly, medially, and superiorly to attach to the femur on the lateral side of the medial condyle. This ligament prevents backward displacement of the tibia or forward sliding of the femur. The knee capsule is heavily reinforced by muscle tendons. Most important are the strong tendons of the quadricep muscles of the anterior thigh and the tendon of the semimembranous muscle posteriorly. The greater strength and tone of these muscles is the less the chance of knee injury. The knees have a built-in lock device that provides steady support for the body in the standing position. As we begin to stand up, the wheel-shaped femoral condyles roll like ball bearings across the tibial condyles, and the flexed leg begins to extend at the knee. Because the lateral femoral condyle stops rolling before the medial condyle stops, the femur spins or rotates medially on the tibia until the cruciate and collateral ligaments of the knee are twisted and taut and the menisci are compressed. The tension in the ligaments effectively locks the joint into a rigid structure that cannot be flexed again until it is unlocked. This unlocking is accomplished by the popliteus muscle, and it rotates the femur laterally on the tibia, causing the ligaments to become untwisted and slack. First, need to remove the skin. The muscle meat. Reveal bone. Oh, ha, ha. And sliding in and out. Should be much easier since this is cooked. Lots of nerves and veins, arteries, skin, fat cells. Okay. Huh. There we go. All this meat away so that we can see the bones. Hmm. Still a bit. So this, like the chicken's knee, this should be the tibia, or tibia tarsus. This little skinny bone right here barely even feels like a bone. Must be the fibula. Here would be this one. So I guess maybe this is the right leg, this the left leg. Fibula on the outside or inside. Yeah. Let's see. Okay, interior. Oh, the fibula is on the outside. Okay. So the raw leg is the right leg, and the cooked leg is the left leg. Okay, let's see. First, we will be looking for the periosteum. It's a membrane, a glistening white double-layered membrane called the periosteum. Around osteobone covers the external surface of the entire bone except the joint surfaces. The outer fibrous layer of the periosteum is dense, irregular connective tissue. The inner osteogenic layer abutting the bone surface consists primarily of primitive stem cells or osteogenic cells that give rise to all bone cells except bone-destroying cells. These cell types are described shortly. The periosteum is richly supplied with nerve fibers and blood vessels which pass through the shaft to enter the marrow cavity via nutrient foramina or openings, perforating sharply fibers, tufts of collagen fibers that extend from the fibrous layer into the bone matrix, secure the periosteum to the underlying bone. Periosteum also provides anchoring points for tendon and ligaments. At these points, the perforating fibers are exceptionally dense. A delicate connective tissue membrane called the endosteum within the bone covers internal bone surfaces. The endosteum covers the trabecula of spongy bone and lines the canals that pass through compact bone. Like the periosteum, The endosteum contains osteogenic cells that can differentiate into other bone cells. Okay, so looking for the periosteum, but it's not cooked bone, not really. This raw bone could be this. You see that? That'd be this. It's like what breaks. Yet. Okay. There we go. Okay. Proximal and distal epiphyses. Okay, now proximal are things that are closer to the center of the body. So this knee joint would be the proximal end. Of the bone, and by where the foot would be, the distal end, and the diaphysis is the middle. Okay, so the epiphysis, singular epiphysis, are the bone ends, epi upon. In many cases, they are broader than the diaphysis. An outer shell of compact bone forms the epiphysis exterior, and their interior contains spongy bone. A thin layer of articular hyaline cartilage covers the joint surface of each epiphysis, cushioning the opposing bone ends during movement and absorbing stress. Between the diaphysis and each epiphysis of an adult long bone is an epiphyseal line, a remnant of the epiphyseal plate, a disc of hyaline cartilage that grows during childhood to lengthen the bone. The flared portion of the bone where the diaphysis and epiphysis meet, whether it is the epiphyseal plate or line, it's sometimes called the metaphysis, meta between. Okay, let's see if we can get to the proximal epiphysis of the tibia. These bones. Let's cut away some more meat on the raw one. Sure is a lot of meat. Okay, it's covering here. In articular cartilage. Yeah. That's the articular cartilage. Yep. All right. Oh, see the attachment. Muscle. See. Okay. Okay. Here we go. Okay. Better image. Okay. Articular cartilage. Articular cartilage. Structure type. It is a type of hyaline cartilage. Hyaline cartilage, which looks like frosted glass when freshly exposed, provides support with flexibility and resilience. They are most abundant skeletal cartilages. Their chondrocytes are spherical, and the only fiber type in their matrix is fine collagen fibers, which is detectable microscopically. Colored blue skeleton hyaline cartilage includes articular cartilages, which cover the ends of most bones at movable joints, costal cartilages, which connect the ribs to the sternum or breastbone, respiratory cartilages, which form the skeleton of the larynx, voice box, and reinforce other respiratory passageways, nasal cartilages, which support the external nose. Okay, so now I think maybe it is this Okay. Into the spongy bone. Spongy bone. See. Head. First, we're supposed to read about diaphysis, a tubular diaphysis. Dia through physis, growth or shaft, forms the long axis of the bone. It is constructed of a relatively thick collar of compact bone that surrounds a central medullary cavity, middle or marrow cavity. In adults, the medullary cavity contains fat or yellow marrow and is called the yellow marrow cavity, but I believe in chickens I read somewhere that theirs is mostly red marrow. Okay, trying to break diaphysis. Is this gonna break? Maybe not. Really don't want chicken guts on my book. Let's see. Get some help. head off. Location of hematopoietic tissue in bones. Hematopoietic tissue, red marrow, is typically found within the trabecular cavities of spongy bone, of long bones, and the diploe of flat bones. For this reason, these cavities are often called red marrow cavities. In newborn infants, the medullary cavity of the diaphysis and all areas of spongy bone contain red bone marrow. In most adults, the fat-containing medullary cavity extends well into the epiphysis, and little red marrow is present in the spongy bone cavities. For this reason, blood cell production in adult long bones routinely occurs only in the heads of the femur and humerus, the long bone of the arm. The red marrow found in the diploe of flat bones, such as the sternum, and in irregular bones, such as the hip bone, is much more active in hematopoiesis. When clinicians suspect problems with the blood-forming tissue, they obtain red marrow samples for these sites. However, yellow marrow in the medullary cavity can revert to red marrow if a person becomes very anemic, needs more red blood cells. And lastly, spongy bone. Let's see. Every bone has a dense outer layer that looks smooth and solid to the naked eye. The external layer is compact bone. Internal to this is the spongy bone, also called trabecular bone, a honeycomb of small needle-like or flat pieces called trabecula, little beans. In living bones, the open spaces between trabecula are filled with red or yellow bone marrow. Right. Very nice. This has been the chicken leg anatomy and physiology lab for Dr. Judith Davis at FSCJ. And the book that I've been reading out of is Human Anatomy and Physiology, 9th edition, by Elaine N. Marieb and Katja Hohen. Thank you very much.